Shall I start, sir?
Sure.
So, Mr. Sivanandam, 75 years, male, weighing 72 kg, height 165 centimeter, BMI 26.5, came with the chief complaints of a swelling or a growth over the right lateral aspect of the tongue for the past 6 months, complaints of pain over the swelling for the past 2 months. History of presenting illness. Patient was apparently normal 6 months back. He noticed a growth over the right lateral aspect of the tongue. It was non-progressive. It was associated with pain was for the past 2 months. There is history of difficulty in chewing the food. History of tooth decay present, and he has replaced 17 teeth with artificial fixed dentures. There is no history of loss of weight, loss of appetite, or easy fatigability. No history of dysphagia or breathing difficulty. No history of loss of taste, halitosis. No history of fever, cough, cold. No history of drug allergy. Past history, he was a known diabetic since 10 years on oral hypoglycemics, tablet metformin 500 mg VD. There is no history of hypertension, tuberculosis, bronchial asthma, epilepsy, hypothyroidism. Surgical history, he has undergone TURP in 2013 under spinal anesthesia, and history of biopsy done for the tongue lesion last month under local anesthesia. Personal history, he was an ex-smoker, alcoholic, and he has stopped taking both 40 years back. He takes mixed diet, normal bowel and bladder habits, no history of tobacco or betel nut chewing. Family history, no history of similar complaints in the family. Socioeconomic status, upper middle class. Coming to the general examination, the patient is conscious, oriented, moderately built, afebrile, no pallor, not icteric, no cyanosis, no clubbing, no pedal edema, multiple small cervical lymph nodes palpable. Vitals, pulse rate 84 per minute, felt in all peripheral, normal in volume, normal in rhythm, felt in all peripheral vessels, no radial or no radiofemoral delay. Blood pressure in sitting posture measured in right upper limb, 128/80 millimeter of mercury. Saturation 100% in room air, and respiratory rate 16 per minute, thoraco-abdominal type. Coming to the airway examination, mouth opening is adequate. Mallampati grading is 3. The bilateral nose and opening is normal, no deviated nasal septum. Mouth opening admits 3 fingers. Interincisor distance is 5.5 centimeter. Thyromental distance is 6.5 centimeter. Hyomental distance is 5.8 centimeter. And sternomental distance is 13 centimeter. Artificial fixed dentures is present. No loose tooth. Neck movements, neck flexion is about 25 to 30 degree and normal. Neck extension is normal, confirmed with the Delicans test. Thyroid and cricoid cartilage normal. The TM joint mobility is normal. Coming to the local examination, inspection, there is no facial deformity. Oral hygiene as of now is good. Fixed dentures plus. Tongue examination, tongue is normal in size and shape, pinkish red in color, and it is mobile in all directions. A single ulceroproliferative growth of about 2 into 2 centimeter is seen over the lateral aspect of the tongue and posterior 2/3. Surrounding area over the tongue looks normal, and other areas of the oral cavity is normal. On palpation, the size of the growth is confirmed. Margins are irregular. It is tender and erythematous and does not bleed on touch. Lymph node examination, multiple small cervical lymph nodes are palpable on the right side and left side. No other swelling or growth elsewhere is seen in the body. Systemic examination, cardiovascular system, S1, S2 heart, no murmurs. Respiratory system, bilateral air entry equal, no added sounds. Para-abdomen, soft, no organomegaly. Summary, a 75 years male diabetic with a history of ulceroproliferative growth in the right lateral border of the tongue for past 6 months. And the biopsy revealed squamous cell carcinoma, well differentiated of the tongue, is now planned for wide local excision.
Okay. Is wide local excision alone or primary closure or any reconstruction also planned?
So since the growth is only 2 into 2 centimeter, they did wide local excision on this.
So they can close the tongue
Yes, sir.
primarily. Rest of it.
Yes,
No
primary
risk.
closure then. Yes, sir.
Is there any history of bleeding while brushing or while chewing food
Bleeding
in the
while
throat?
chewing, sir.
Is there any, does the patient, did you
No.
ask for history of bleeding from the
Yes,
ulcerated
sir.
throat?
No, sir. There was no bleeding, but pain was only there, sir.
The pain.
Pain during chewing, sir.
With the pain while chewing and swallowing, is it possible for the patient to maintain his weight? Is he able to eat so well to maintain his normal weight in spite of the growth and pain?
So the patient actually said, since it is on the right side, always used to chew on the left side and swallow.
That's right. Okay. He
Yes.
manages somehow.
He
He has
manages
got his
somehow and
own
so.
adaptation.
Yes, sir.
Okay. Right. Now, when you examine the tongue for ulcer, of course, this is not a point for us, but we have some relevance to that. Where
Okay.
all do you normally can see a malignancy or an ulceration in the tongue? How do you classify the tongue ulcers according to the location? Do you have any idea about it?
Anterior two-third and posterior one-third. Mostly it's classified like this.
Can be anterior, middle,
Anterior
and
two-third,
posterior. Not
anterior middle.
actually
Okay.
anterior, middle, and posterior. And anterior, why this classification is important for us, even though surgeon has to decide where the exact location is. Does it have any relevance to us as anesthesiologists? If there is an ulcer in the anterior uh, part of the, when you ask the patient to protrude the tongue, you see it almost very close to the tip of the tongue in the lateral aspect. The other person has a ulcer and the growth in the middle portion of the tongue when they protrude. The third one has got almost in the posterior aspect, very close to the molar. Is there any clinical relevance as an anesthesiologist for you to know these three locations where the ulceration can happen?
So mostly the posterior swelling will hinder with our airway securing, sir.
Very good.
While
Not
passing
only
the
that, it will invariably involve the floor of the mouth also.
floor
Okay?
of the mouth. Yes.
So whereas if it is in the anterior, patient will be able to protrude the tongue
Protrude the
nicely,
tongue. Yes.
and majority of the time it will be amenable to local resection and primary closure of the defect. So it may be possible even with the middle portion of the tongue where the patient may have a growth. So anterior and middle portion ulcerations and malignancy, if detected early, the surgeon can easily resect that, giving a wide normal margin of the tongue tissue and close it primarily under local infiltration anesthesia itself. It will not be a challenge for us, and our role will be when we to give some monitored anesthesia with the sedation. On the contrary, if the growth is in the posterior aspect involving the floor and the restricted mobility of the tongue, when you ask the patient to protrude the tongue, majority of the times patient with a posterior growth will never be able to do that because it will go on to involve the floor of the mouth, and neglected cases will even infiltrate into the bone and make it a major problem where you will have to achieve a wide excision, you may have to even resect the bone and then reconstruct the whole thing. So that knowledge of where exactly the location is important not only for our examination of the airway and its management, but also the possible surgical repair that is can be done depending upon the location. So that
Okay,
knowledge is
sir.
very important. So these cases are normally kept in the exam only for identifying and testing your knowledge on management of a difficult behavior. Now, luckily, you have got a patient who has got an ulcer which can be easily managed under local institution anesthesia without any challenge for us. So let us now change the case scenario from this very simple cancer tongue to a neglected, very advanced case of cancer tongue which has gone on to infiltrate into the neighboring area, floor of the mouth, teeth, mandible, and the person has got a huge swelling which is very visible even on inspection without going in for any other examination. And he requires a hemimandibulectomy, a glossectomy, and the soft tissue excision with neck dissection for the involvement of the nodes in the neck and a reconstructive procedure. So if we change that scenario only, we can have some amount of useful discussion on this topic. Okay.
Yes.
So I am changing your case scenario from this very simple small growths which can be managed by local infiltration and surgical correction. I am changing it to be a condition where still the Malambati score is 3 because the patient is not able to open the, I mean, the structures visible inside the mouth. You can't see anything beyond the hard palate, and there is a restricted mouth opening, and patient has got severe pain in the structures. If that is the case scenario, and they send the patient for wide excision reconstruction with either a pectoralis major pedicle flap or a free radial forearm flap or a free fibular graft with reconstruction. If these three options have been put as a surgical repair, how are you going to manage this patient?
Okay, sir. Sir, after confirming the diagnosis, first I would like to investigate the patient answer.
Okay.
Routine blood investigation, CBC, RFT, LFT.
One more thing, in your history, you said he is a diabetic of 10 years duration. Would you like to ask
Yes, sir.
him for any other information on that?
So any history of joint stiffness?
Okay. First and foremost, whenever a patient says he's a diabetic of 10 years, 15 years, elderly patient coming to you for any procedure, forget the cancer tongue, what are the questions that you would like to ask that patient? This I have been telling in every class whenever we discuss patients coming with a comorbidity of diabetes. So what are all the standard questions that should be asked to any patient coming with a comorbid condition of diabetes mellitus of long duration?
The history of
There are
any
some standard questions we want to ask to assess the involvement of the various systems because of chronic diabetes.
Yes, sir.
Hmm.
Any history of
What is the first and foremost question you will ask if a patient says, I am a diabetic for 10 years? What is the first question you should ask that patient?
Duration of illness.
Duration of.
No, patient says 10 years. Already he has given you the answer. Then duration of illness is the same. He is going to say 10 years only.
The drugs we drugs he is taking off for
first question.
diabetes.
When a patient, any patient tells you, I am a diabetic for 10 years, 15 years, 12 years, 5 years, 4 years, what is the first question that you would want to ask? This will be useful to you when you deal with a patient diabetic patient coming for below knee amputation or a diabetic patient coming
Autonomic neuropathy symptoms. Neuropathic symptoms.
They develop it, the first question will they develop autonomic neuropathy on the day one of their disease itself?
No, sir.
So please remember that the first question you should ask whenever you come across a diabetic patient, how his diabetic condition was detected.
Okay,
Okay?
sir.
Why it is important? Nowadays, how do people come to know that they are diabetic? among the
So by the
society.
symptoms,
By
symptoms like
earlier it
giddiness,
was
loss of weight.
polydipsia, polyuria, polyphagia, isn't it? Do those symptoms occur now routinely in all patients who develop diabetes?
No, sir.
Even if you read articles written by very popular and very experienced diabetologists, they have said that that old textbook classification, I mean description of polydipsia, polyuria, polyphagia is no more prevalent in majority of the diabetic patients. Okay, so it is found out incidentally by master health checkup or checkup for their employment or insurance. That is the first and foremost method by which they come across. Second thing, when you ask them how your diabetes was detected, they'll say, I used to wake up for my toilet needs 2 or 3 times a day, a night. So I went and consulted my doctor. He asked me to get my blood sugar tested, and that is how. So nocturia more than polyuria is another earliest indication for detecting diabetes nowadays. The third thing is majority of them either lose weight or uh, feel very exhausted and tired. So with that complaint, they go to the doctor, and then once they check that, that immediately they are found to be. So that question tends to, because majority of the patients do not realize that they have diabetes. So diabetes is detected in majority of them after it has been there in them for quite some time. That is the main important point all the diabetologists are stressing nowadays, that it is not presenting in the classical way. So periodic testing for fasting postprandial and HbA1c only will reveal that you are becoming a diabetic. So symptomatic uh, detection is becoming less and less. So only the alternate methods are useful. So by asking this question, what are we gaining? That whether it was detected at the very early stage or whether it was detected after the patient silently suffered diabetes for quite some time and then it was detected. Okay, right. So that is the first and foremost question that you want to ask. Second thing, immediately once you have detected that it was detected by chance or by symptoms, then if it's already suffered symptoms and then come to the doctor and then detection, what is the next step you should ask? What is the next question that you should ask the patient?
Uh, did you
Once the
since
patient
normal
goes to the doctor,
duration of the symptoms, sir? Duration of the symptoms.
see, patient goes to the doctor by either random testing or by symptomatic presentation. He has been diagnosed as a
Right.
diabetic patient. Okay, it has been
Okay.
confirmed. So, what is the next information you want from the patient?
Whether it's controlled or
Diet
Imagine
uncontrolled.
yourself as a
control.
general.
Not diet.
Huh?
Diet about the
Ah,
diets.
whether the patient was immediately started on
Started
oral
on drugs or you was
antidiabetic
on diet.
medication or whether they advocated initially only lifestyle modification.
Lifestyle modifications. Yes, sir.
So the doctor would have told you, so your diabetic condition is very mild. Now your HbA1c is only 6.1, but your fasting blood sugar is about 110, 115, and postprandial is only 140. So you are in the beginning stage of diabetes. So try to cut down on your carbohydrate intake, go for walk, reduce your weight, cut down on your alcohol, smoking. So that advice may be given without starting the medications right away. Or if the values have been very high and HbA1c at the time of detection itself 7.58, then they would not wait for all the lifestyle modifications. So they will say go for lifestyle modification, along with that start the medications also.
Drugs.
Okay,
Okay.
right? Right. So what is the current uh, line of treatment advocated by diabetologists when the patient is an established diabetic mellitus patient of say moderate to severe degree? Just like hypertension, we were treating them with beta blockers earlier. Then we switched over to calcium channel blockers. There is a Joint National Commission for Hypertension, which reviews every year. The 6th, 7th, 8th, the commission has been periodically formed to change the pattern of treatment. So the 6th commission recommended beta blocker, 7th commission recommended calcium channel blocker. Now the 8th commission recommends what drug for hypertension?
AC inhibitors.
AC inhibitors and ARBs. Okay, that is the
ARBs.
correct. Okay, so like that for diabetes, earlier it was metformin, that is biguanide, then sulfonylurea, and biguanide combination. Then when these four inhibitors came, that was the thing. So what is the current recommendation of diabetic treatment? What are the drugs with which the diabetologist will start the patient if the patient directly goes to a diabetologist for blood sugar control? Will they start on metformin and sulfonylurea like Amaryl or other Yammer? Or what is the current
With alpha glucosidase inhibitors,
SGLT2 inhibitors.
SGLT2 inhibitors,
SGLT2?
alpha glucosidase inhibitors like voglibose.
No. That is not the drug. It is a combination of metformin with dipeptidyl peptidase 4 inhibitor. Okay, Janumet.
Glimepiride.
Glimepiride is a sulfonylurea. It is dipeptidyl peptidase inhibitor, DPP4 inhibitor, and metformin is the current recommendation for oral hypoglycemic agent therapy for diabetes mellitus. Please go and refer. That is the current recommendation. If it is not controlled with that, then you add sulfonylurea. And if it is not very high values initially, straight away go for SGLT2 inhibitors. So that is the current recommendation in diabetic management. Please check with your diabetology friends or go through Google and see that is the current recommendation that is required. So, but the drug therapy is very important. What are the drugs that have been started and whether it was getting under control with the initial drugs that were prescribed? If so, how long he has been taking those oral hypoglycemic agents, or whether he needed escalation of the dosage or change of drugs. Why that the history of drug treatment is important? So the first question, how it was detected. Second question, the mode of treatment, whether it is lifestyle modification with OHA, or even some people may be put on insulin straight away if they had other associated symptoms because they had been harboring diabetes for quite some time without any knowledge, and suddenly you detect at the time their HbA1c is very high and the sugars are skyrocketing. So in that situation, the diabetologist may even prescribe insulin in the initial stages itself. Is there any important relevance to knowing all these points for us?
So response to the drugs and history of any symptoms of hypoglycemia, the patient is on diabetic drugs.
The response is not. What you have to know is if the patient has been requiring escalation of the dose, say they start on metformin 500 mg and the Janovia, which is 50 mg. So that combination they give and ask them to come back for review after 1 month. There is no appreciable improvement in the condition. Then they increase metformin to 1000 milligram and make it twice. The have to be taken morning and night, or they need to add glimepiride or other sulfonylurea also. Like that, if they are requiring more and more drug, that means their condition is not coming under control properly. So these patients are more prone for target organ dysfunction, like kidney, heart, and the retina. Okay, so there, when the blood sugars are not coming under control with the medications, those are the patients who rapidly deteriorate because their target organs will get affected much faster than those. Some patients, you start them on metformin 500 milligram for 10 years, they may be taking the same thing and they may be comfortable and their blood sugars may be quite reasonably good. So those patients, you don't expect them to develop any target organ dysfunction. So the response to the therapy indicates whether the patient is prone for target organ dysfunction and whether you have to look into those organ functions also before we take them up for surgery. Okay, that is the secondary point that you have to ask these patients. Okay, what is the third question you should ask? How does the patient know that the treatment is working for him?
So whether repeatedly we will do fasting and postprandial values and HbA1c
How,
values
so
for
whenever a
every 2 to 3
patient says
months.
he has been a diabetic for 10 years, 15 years, the third question you should
How
ask is,
frequently he will test his
how
blood
frequently
sugar
he has
levels.
been checking his blood sugar levels to
Blood
see
sugar
whether
levels.
the treatment is working for him or not.
Respond. Yes.
So what are the available options for checking nowadays for patients? Should all of them go only to the lab and give their blood sample and get it done?
So they can check by themselves with the glucometers at home itself.
It's called, what is it called? Is there any name by checking with the glucometer at home and checking your blood sugar levels? Is there a name for that?
Capillary.
HGM.
Capillary blood glucose. Sir?
No, the sample is HGM. Home glucose
Home
management.
glucose
It's
monitoring.
called home glucose monitoring or home glucose
Yes.
management. Okay. So that is the third question that is every diabetic patient should be asked, whether they have been checking their blood sugar at home to see whether it is getting under control, and periodically whether they are going to the lab to give a sample of venous blood and then trying to find out their HbA1c value also to see the previous 3 months control. And what other, supposing 10 years duration of diabetes, what other, how do you test the target organ dysfunction in this patient?
Sir, for screening the retina for diabetic retinopathy, sir.
Okay.
Ophthalmic examination and
Okay.
looking for renal function test.
Renal function is the first one, that is urea creatinine. Will it be the one to change rapidly, or what is the earliest indicator to
Microalbuminuria.
microalbuminuria? Okay, so all diabetic patients should be advised to check for their microalbumin levels at least once in a year if they are a chronic long-term diabetes. Okay, so that question also you can ask them to find out whether they are getting target organ dysfunction. So why I am discussing so much about all these things in CA tongue case is currently the examiner need not ask anything about CA tongue at all in practical exam. So they can jump to the other condition and ask you. So your patient is not an hypertensive patient, right?
No, sir.
Does
Yes,
he have
sir.
hypertension also?
No, sir.
No, he is only a diabetic with a
Diabetic.
CA tongue. And now we have changed the scenario from a simple small lesion which can be excised and closed to a major lesion where there is an anticipated difficulty airway and a major long procedure planned for as a surgical emergency, surgical treatment. Now, supposing it's too huge a growth, what are the options? Would they straight away go for surgery, or are there any alternate modalities of treatment available for this cancer?
So radiotherapy.
Radiotherapy, very good. Can they give
chemotherapy
chemotherapy?
And chemotherapy and radiotherapy to downregulate the.
Okay. Supposing the oncologist, the patient has gone to an oncologist, medical oncologist, and because the surgeon feels that surgery straight away is going to be very tedious and very produce more morbidity. So he wants the oncologist to reduce the bulk of the tumor by radiation and chemo, and then refer the patient back for surgery. In that case, what is the difference? In a patient who has been treated with radiation and chemo or chemo radiation coming for surgery, and the patient coming for surgery straight away as the first choice.
The patient the general condition will be the patient will become more emaciated following chemo and radiotherapy. IV access will be difficult if the patient is on repeated chemotherapy, and following radiotherapy, there will be scarring of the skin. So stiffness of the jaw, neck extension will be present since it is a oral carcinoma.
Very good. So the difference is the patient who has undergone chemo and radiotherapy will have more problem when they come for surgery because of the tissue restriction, scarring, fibrosis, as well as the effects of chemo on the whole body, producing nausea, vomiting, hair loss of appetite, and not able to eat. So all these associated general health deterioration are possible. So that must be the answer that we have to keep in mind. Now let us think that this patient is first referred, because surgery is the first option for any oral cancer. Then only the chemo and radiation come, and they may be given later also to prevent a recurrence. So chemo and radiation as a first line of treatment for oral cancer is only, as I said, if it is a very huge tumor and they want to reduce the size or debulk it before surgery, then only patient is referred for radiation and chemotherapy. So let us imagine that your patient has got a huge growth, but the surgeon feels it can be operated, and he plans to take up the patient for the procedure I told you straight away as a first surgical option for treatment. Now tell me, what are all the steps that the patient is, you have seen the patient, you have given assessment because other parameters are all okay. Patient is posted for the planned surgical procedure and you are the anesthetist. So tell me all the steps how you will manage this case.
Okay, sir. I have given assessments
and main concern.
So first I would investigate the patient with all routine investigations, ECG, chest X-ray. Since it is a major procedure, I would make ready for blood grouping, typing, cross matching, make the blood available. And purely the biopsy of the tumor would have been done and confirm the diagnosis with the histopathological examination.
Also.
And CECT of the head and neck to confirm the bony infiltration. And MRI tongue.
It's more of a surgeon's problem. So, as an anesthesiologist, what are your pre-op evaluations? What is your plan? How are you going to execute it? That is all what we want in the examination. Because the exam don't necessarily say what is not required from our side. So try to restrict your answer to the main points without wasting time on unwanted details.
Okay.
What is your main concern in this case? Any oral cancer?
Since he's a diabetic, I would check the blood sugar levels, whether he's adequate glycemic control before the surgery.
No, and see, whenever they are giving you a oral cancer case, first answer is always airway.
Airway.
Okay? So your plan for securing the airway, because this surgery, my wide excision with a hemiglossectomy, mandibulectomy, can you do it under regional technique?
No, sir.
No. So what is your anesthesia going to be?
So since it is a huge tumor obscuring the airway, my choice of anesthesia would be a awake fiber optic intubation.
No, no. What is your anesthesia of choice? Is general anesthesia.
General anesthesia. Yes, sir. General anesthesia.
See, I told you it cannot be done under regional. So the next option is only GJ.
General anesthesia. Yes.
So for giving general anesthesia, you need to secure the airway. So that is the first and foremost concern. Diabetic control and all that we can adjust with insulin, everything. That is not our major concern. But pertaining to oral cancer cases, if they are giving that case in the examination, your answer should focus mainly on the airway management.
Airway.
That is the reason why these two cases are kept there. So now, how will you plan your airway management? You said you awake fiber optic intubation is a first choice. That's correct. That is also a safe option. Supposing a case like yours, instead of a huge growth, a case like a small lesion in the lateral aspect of the tongue, which also has some involvement in the floor of the mouth. For that case also, it's not a huge growth, but for that case also, they are planning to remove part of the mandible, not a whole total mandibulectomy, but segmental mandibulectomy and tongue resection. If they plan that and mouth opening is good, would you still like to go for awake fiber type, or can you do a regular induction and intubation?
So we can do a regular induction and secure a nasal tube. And priorly, we can get consent from the patient for tracheostomy post-op, sir.
So the answer for this question of oral cancer airway securing is option 1. If it is a huge growth with limited mouth opening, not able to visualize the structures by Malambati, then fiber optic awake intubation and the topical anesthesia will be the first choice. If it is a manageable growth where mouth opening is good, laryngoscopy, trial laryngoscopy can be done, then you can go for regular induction and intubation by the nasal route, and then at the end of the procedure, if needed, we can do a tracheostomy, or if not needed, we can even leave the tube in situ for some time and intubate the patient later when they are fully awake with all muscle power. What is the third option? Go for a tracheostomy straight away.
Tracheostomy earlier.
And the beginning as an elective procedure, tracheostomy, and then give anesthesia through the tracheostomy to maintain the whole surgical procedure. These are the three simple options. If you remember and tell in the examination, that is more than enough.
Okay.
One is awake fiber optic intubation. Second is induction and intubation. And third, elective tracheostomy. And for the two previous procedures or managements, you may have to think of doing a tracheostomy at the end of the procedure, depending upon the extent of dissection and the reconstruction that is done, because a lot of edema and swelling will happen. And if you just like that take out the tube, the nasal tube that you have put in, patient may go in for airway obstruction. So in that situation, surgeons may prefer to do a tracheostomy after completing the surgical procedure, because some feel that the tracheostomy tube may hinder the proper neck dissection they are doing. So I may prefer to do it at the end. So these are the three simple airway managements that if you remember and tell in the exam, that is more than enough. One is awake fiber optic nasal intubation. Two, induction and intubation again by nasal route. Both the things can be followed by tracheostomy at the end of the surgical procedure. Third is, instead of putting and trying and passing a tube tracheally, straight away go for an elective tracheostomy before starting the entire procedure, and then give anesthesia to the tracheostomy tube and complete the surgery, and retain the tracheostomy for 3-4 days post-op, and when every edema other things are settled, we cannulate the patient and then send the patient home. Okay, this is how the airway management is planned. So for this only they keep these cases and ask you to present these cases in the examination. Now you have planned for elective, awake nasal intubation and successfully intubated. What type of tube you want to use for this nasal intubation? Is there any specific type of tube?
If hemimandibulectomy is also planned, we can use a flexometallic tube, sir.
Okay.
Since the manipulation will be more.
Hemimandibulectomy, flexometallic tube. Why not nasal ray tube?
Yes, sir. Pardon?
Nasal ray tube or not
Me-
nasal ray tube. RAE.
Can be used, sir.
It is not be. It is not be an ideal choice also.
I have not used until
You
now,
have
sir.
not.
So
Very good. Excellent. Excellent. If you have not seen or done, please commit yourself and say that. That is not at all a mistake. So those who
okay.
are, I think they have announced the exam dates for practicals. So those who are going to appear for practical exam, please remember that if you have not seen or done, there is no harm in admitting the practical exam that I have not seen that tube, I have not done that. They will not penalize you for that at all. Okay, right. So that is another option. Nasal ray tube
Okay.
also is an option which can be practiced, and so that is the second thing. What are the other problems in this case? So airway management has been successfully done with fiber optic intubation. What are the other challenges that you are going to face? Supposing they want to do a pec major flap, or they want to do a radial forearm flap, or they want to do a free fibular graft. These are the three surgical options for reconstruction after excision, wide excision of the tumor with the soft tissues and bone which have been involved. The neck dissection. What are the other challenges? First challenge has been met successfully. Airway has been secured. What are the other challenges that you will face in this case?
The pain management.
Pain management, very good. Okay. That is common for every surgery, not only our oral cancer surgery. Any surgery, pain management is important. But in this particular case, any other problems other than pain is common to every surgery. Is it a long duration surgery or a very short duration?
Yes, it's a
Long
long
duration.
duration surgery.
Especially if they plan to do a microvascular
Elect-
anastomosis or a free tissue transfer, it is going to take even 8 hours, 10 hours also possible. So
Yes, sir.
when the surgery is likely to be very long duration surgery, what are all the challenges that you have to face?
We plan for elective post-op ventilation and then extubate the patient if there is a long duration
Intraoperative,
surgery.
first talk about intraoperative problems, then you can talk about post-operative problems.
Intraoperative blood loss,
Very good. So extensive dissection.
extensive
removal,
dissection
you
for
have to
blood loss.
anticipate blood loss. Very
Blood
good.
loss.
Okay. Hmm.
And if it is more, we can transfuse the
Suppose
blood.
a surgeon says, I want the room temperature to be 16 degrees.
Hypothermia. Hypothermia.
Very good.
Okay.
Right.
Hypothermia. As arterial blood gas monitoring should be done, sir,
Hmm.
to detect any
Suppose
acidosis.
microvascular surgery, surgeon says, I am going to do a microvascular surgery by radial forearm or a fibular graft. What are the requirements for microsurgery? Because this sort of cases nowadays are single sitting reconstruction is done. Previously, they used to first exercise and leave a big hole in the face and allow the patient to recover for over 2 weeks, 3 weeks, then bring them back and do a reconstruction. But nowadays, they plan it is a combination of oncology surgeon with a plastic surgeon or a microvascular surgeon, and they do the reconstruction in one sitting. So it takes even 10 hours, 12 hours, and they complete the whole thing. So what are all the requirements for microvascular anastomosis? Supposing the patient
BP
develops
management.
hypotension intraoperatively.
Hypotension.
Hypotension, is it advisable during microvascular surgery?
No, sir.
No,
We have
sir.
to maintain the blood
Mean
pressure.
arterial pressure should be maintained
Mean
at all
maintain
times.
up all
Otherwise,
times.
the
So
microcirculation will close. Okay, small
Yes, sir.
vessels will go into spasm. So it is very, very important that you have to maintain normothermia, normal blood pressure, normovolemia. These three are very, very essential for microvascular surgery. because
Okay.
of my experience in Stanley Plastic Surgery Department, where we have done more than 500 microsurgeries. I can confidently say if these three factors are maintained well, the surgeon's headache of re-exploration, muscle spasm, clotting, everything will be taken care of. Okay, so normothermia, normovolemia, normotension are the three important requisites for microvascular surgery. And also position. When the patient lies in the same position for 10 hours, 12 hours, what can happen?
Risk of DVT, sir.
DVT, DVT is there for every patient, especially this surgery. Patients in the same position for 10 hours. Pressure
Nerve
shock.
impingement.
Patient can, I have seen cases of necrosis or pressure sores in
Necrosis,
the
pressure
scalp,
necrosis, pressure.
in the neck, in the ear, okay, in the cough.
Okay.
So all these areas you have to be properly padded and then take care of the pressure. And of course, DVT prophylaxis is a must for all surgeries which are likely to take long time. And they may request for anticoagulation because it's a very minute vessel anastomosis under microscope. They want the blood circulation to go on without any thrombus formation. So they may request you for anticoagulation in the form of heparin or low molecular weight heparin, which may cause bleeding in the other sides. So the oncologist surgeon,
Okay,
if he cuts all these things, they may have to look after the hemostasis also. Okay, so these are the things that you have to take care of intraoperatively. And what about the post-op? You said about elective ventilation. Supposing patient is breathing adequately, conscious, fully oriented, opening his eyes, then what is the airway management in the post-operative period?
so depending upon the extent of dissection, we can do an elective tracheostomy and wean the patient off the ventilator, sir.
Okay. Supposing it is a minimal dissection, partial mandibulectomy only, they are just put up plate and to maintain the jaw configuration without any much damage. They have not taken any fill flap. They are able to get a local skin itself for cover. Mouth opening is adequate. And your surgeon says there is no need for tracheostomy. Then what is your advice? How will you manage?
So since mandible plating has been done, there may be risk of airway edema also. So selectively ventilate for 1 day and give anti-airway edema
Patient's
measures
muscle
and then
power is very, very good. Muscle
slowly
power
wean the
is very
patient.
good. Still, because the patient is the mandible edema, you want to ventilate, or you can leave the patient with the tube in situ.
We can leave the patient with tube in situ
Okay. What is the risk
with
in that?
without sedation and paralysis. So,
Okay. Patient is breathing happily with the tube in situ, and you would just give a supplemental oxygen through a T-piece. But
okay.
what is the risk in that? And you plan to extubate the next day after surgery.
Risk of
Risk of patient breathing
breathing.
spontaneously with an adequate size tube nasotracheally intubated. What is the risk that is involved in that? A tube in throat in a conscious patient, what will it do?
Tissue necrosis. It's a long time.
Usually, when you leave the tube in place without supportive ventilation, and the patient's muscle power is
Airway
very
edema,
good,
cord
you
edema,
can always deflate the cuff. There is no risk of
deflate.
tissue injury in that. Normally, we do like that only. We don't inflate the cuff to that extent that when we do it during anesthesia.
Okay.
I think you have not seen such patients with the tube in situ, now breathing spontaneously.
Breathing spontaneously.
Secretions and blockage of the tube.
Secretion block.
That is,
Okay.
that is the most important risk
You block.
So if the tube gets blocked because there is a foreign body in the trachea, so the tracheal and laryngeal secretions will be more, and they can, unless the patient has got an effective cough reflex and you are periodically cleaning the tube with proper suction, there is a possibility that there may be a mucus plug blocking the tube and causing airway obstruction. Okay,
Okay.
so that is the only risk in leaving the tube when the patient has got full muscle power and able to breathe adequately and generate a good tidal volume. So in that
Okay.
stage, if you want to remove the tube, what other precaution you can take?
So we can extubate the patient with
Hmm.
like a difficult airway extubation, sir, by keeping surgeon standby for tracheostomy, keeping all the difficult airway cart ready, and then extubate the patient.
Stand with the patient for 24 hours like that.
Oh, sir, while extubating, I'm saying, sir.
Okay, but how long you can wait like that after extubation? Supposing after 4 hours he develops a spider, will you come and do an tracheostomy at the time, or is there any other simple way where you can be reassured that you can re-intubate the patient? Have you heard of airway exchanger?
Airway exchange catheter.
Airway exchange catheter. If you put that one, you can
Okay,
always
sir.
railroad anytime, isn't it?
Okay, sir. Okay, sir.
That is the option. Okay. So
Okay.
that these are the three options again for post-op care. One is do a tracheostomy, either allow the patient to breathe spontaneously through that if they have got good muscle power, or electively ventilate if they need ventilatory support, or in case you plan to sedate them heavily to avoid the pain, then you may need to ventilate them. Or
Okay.
you can leave the tube in situ with proper tube care postoperatively and use supplemental oxygen if the limited resection is done and there is bone stability. That is, mandible should be intact either by a plating or by partial resection and plating. Then if the mandibular stability and bone stability is there, you can always leave the tube in situ. The third option, if you are worried about the tube getting blocked, always put an airway exchanger. There is a quick airway exchanger available through which you can oxygenate also. Nowadays we have airway exchangers with oxygen ports through which you can continuously give oxygen also, and leave that in situ and then try to extubate. And in case of emergency, put in the tube using the exchanger as a railroad technique and pass the tube into the trachea and save the patient. Okay, so these are
Okay,
the
sir.
things that are commonly asked for. So with that in mind, I'll just go for a presentation to show what you have to know about